Good morning, it's 8 o'clock. I'm Shannon Switkowski, the clinic coordinator for Cardi-OH. Welcome to week 3 of our Tackling Type 2 Diabetes series. So I will turn it over to introductions. Kathleen.
Hi there, I'm Kathleen Duggan, endocrinologist at OSU. I'll be facilitating this session.
Thank you. Is Dr. Beverly?
Yeah, I'm here. Hi, good morning. I'm Liz Beverly. I'm from Ohio University Heritage College of Osteopathic Medicine. Morning.
Thank you. Good morning. Dr. Werner?
Yeah, I'm Jim Werner from Case Western Reserve University and University Hospitals, and I'm a behaviorist.
Thank you. And Dr. Przezinski?
Good morning. I'm Adam Przezinski. I'm a sociologist in the Center for Healthcare Research and Policy at Metro Health.
Great. Thank you so much and welcome. And I'll turn this over to Dr. Duggan.
Great, so here is our schedule for this morning. We'll start off with a didactic presentation and our case study, followed by a wrap-up. Please remember to stay at the end to complete that post-clinic survey and get your wrap-up details. All right, so here's our series, and our didactic this morning is lifestyle approaches to management of type 2 diabetes. Our presenter is Dr. Christopher Taylor, who is a professor of health sciences and medical dietetics at Ohio State University.
Okay, great. Welcome everyone this morning. I am going to work through talking about dietary and lifestyle and physical activity changes and how we can implement those within our primary care environment to facilitate patients. So this is some work that I've done with Dr. Randy Wexler in family medicine here at Ohio State, where we've been working on linking together patients in primary care with nutrition counseling to impact outcomes. We've done this with hypertension. We're doing some work in diabetes now. So I'm going to share some of the work and the insights that we've had with that, as well as kind of some of the broader science around nutrition, physical activity, and diabetes. All right. Oh, a little lagging in the click. Okay. So when we start thinking about management of diabetes and how the guidelines are established, there's always a description for each one of our chronic diseases about the role of lifestyle behavior modification within the treatment strategies. And these include physical activity and dietary patterns within the various guidelines, especially for diabetes. The recent report for diabetes care, which we talked about just a couple of weeks ago, has updated these aspects in terms of how different nutrients and food groups have a role within diabetes. And then this also has to function within the role of pharmacologic treatment. So it's a balance between lifestyle behavior and pharmacologic treatment and how these all play a role. And where I think it's important is to kind of reset ourselves in terms of how we're managing blood glucose and hyperglycemia, and where are some of these factors that are playing in. So when we consume this meal in the bottom of the screen, we eat that food, we have this nice big ball of rice, a giant ball of starch. That's going to end up as a large bolus of glucose going into the system. It's going to stimulate the pancreas to recognize that we have hyperglycemia. It's going to release insulin. And then we have the insulin receptor on the cell. It's basically picking up our radio waves and helping us clear the blood or the glucose, getting it out of the liver into the muscles, storing it into glycogen, and reducing our blood glucose levels. Okay. But once we come back to this meal again, and we eat this bolus of rice, and when we start having insulin insensitivity, it's kind of like having that antenna on your radio when you used to be able to walk past the radio and it would start to fuzz the sound as you come by. We have less of a reactivity of insulin, more insulin resistance, and those meals continue to build and continue to build, and our blood glucose goes up, and our insulin goes up, and our blood glucose goes up, and we continue this cycle, which then we have two mechanisms to address it. We have it by the pharmacologic treatment, or we have it by managing the diet. And optimally, we would be doing this, managing this hyperglycemia and hyperinsulinemia, both through the diet and through the pharmacologic treatment. But this also requires some intensive work with the patient to promote lifestyle behavior change. So I like to think about diabetes control and managing blood glucose around, we have issues of poor insulin production, poor insulin action, which is our ability to clear the carbohydrate. But the other half of the equation is how much of the carbohydrate is actually coming in that needs to be managed. So we're coming off of the throes of summer in Ohio. It's been 90 degrees. The temperature rises, we get warm. And we've got a thermostat that's supposed to monitor this and help us cool us down and bring that core temperature back down. Well, what we're seeing within diabetes and in achieving optimal outcomes for patients is their blood glucose is getting higher and higher, insulin insensitivity, more carbohydrate intake. So we're working with a process to turn that thermostat up. Unfortunately, we're also leaving the kitchen window open. So we're trying to cool the house that's getting too warm, but we're also not controlling the amount of warm air that's coming back in. So it's a process of helping patients really understand that the pharmacology is your air conditioner, but your air conditioner can only work as well as how well you maintain the airflow within the house and can control the extra heat coming in. So much of our work that we need to do is on the behavior side and the counseling side to help patients really understand that the impact that lifestyle behaviors can have in balancing it with pharmacologic therapies. A lot of times patients will come to taking care of their diabetes from, I know I'm taking this medication, therefore the medication will cover kind of all manner of sins. And therefore I don't really have to change my lifestyle, or it's really too hard for me to change my lifestyle. But it's okay because I have the medication. So making those connections, a lot of time the patients are telling us, well, I knew diet and lifestyle was something, diet, physical activity was something I knew I should do, but I have a lot of barriers, and it wasn't really a priority to me until my primary care provider said, frankly, we understand that your diabetes is not under control and lifestyle is going to play a significant impact. And I want you to focus on your dietary behaviors. And I want you to, be referred for nutrition counseling, to diabetes self-management education, to a DPP program. However, but until the physician kind of makes the action to put the priority on it with the patient, they'll commonly put it as something they think they should do, but not something they need to do. So it's now how to kind of fold that lifestyle behavior in within part of their care, as opposed to what they should do while they're taking their medications. So a little bit of evidence around the impacts. As a person who does nutrition research and seeks funding for nutrition research, the constant balance I get is, the constant battle I have is, everybody knows you should eat well, and it leads to health impacts, and it leads to positive health influences. And then we say, okay, so what are those outcomes? Well, we don't know because we can't get the funding, because we already know that diet is good for you. So one of our foundational studies around the impact of lifestyle behaviors on diabetes and diabetes onset, which then has also been linked with various other aspects of diabetes care. But the diabetes prevention program sets an amazing stage for us as we evaluate and really think about what lifestyle behavior can and will do. And this was a study set in the early 90s, and it was set for the prevention of the onset of diabetes. And if we think about the 1990s, it wasn't pre-diabetes at that time, it was impaired fasting glucose. And the number of people that would need to be screened to be identified for impaired fasting glucose at this time is a massive undertaking. And in reality, this original trial was set up to be a study of the drug metformin versus usual care. And the discussion in designing the study was, what is usual care? And the question is usual care what should be happening? The lifestyle, the physical or the diet, the physical activity, the stress management, the pharmacologic treatment, all of these other aspects? Or is it, I think you should lose weight. How should I do that? Yes, you should. So they approached this, this design and added the lifestyle behavior modification group as a method of a second control group. It was usual care as what they thought usual care should be, as opposed to what usual care was at the time. And it turns out that second control group was twice as effective at preventing diabetes, at reducing hemoglobin A1C, at maintaining hemoglobin A1C, promoting weight loss, which then has had 10-year and 15-year outcomes assessed of improvements in both glycemic control, glycemic management, and many other chronic disease risk factors. So we now are mounting the evidence around the impacts that lifestyle can have on chronic disease outcomes. So it creates an additional level of support to bring in the evidence as a practitioner, to bring forward the importance of incorporating diet and physical activity as part of the treatment plan for patients with diabetes. So thinking about some strategies to effectively in assisting eating patterns for patients with diabetes, a lot of the work that I do is around dietary patterns, what people eat, how they eat. And some of the presentations I've given over the past couple of years have hit on some of these elements that I still have people coming up to me at conferences a year later and saying, I'm now asking about this and I'm now asking about that. Because we think about the total picture of carbohydrate intakes. But we also have to consider we want a consistent consumption of carbohydrate throughout the day, which means as we skip meals, it begins to throw off that pattern of consumption throughout the day. But what is often also associated with meal skipping is the fact that there are several nutrients and food groups that we might consume at a particular meal, and we don't often make those up throughout the rest of the day. So fiber is actually one of the nutrients we get at breakfast, and considering the fact we don't eat a lot of whole grains, it has a larger proportion of our whole grains that come from breakfast. So when we skip breakfast, we have a tendency to miss those nutrients and those types of foods that we're promoting, fruit, the whole grains, the low-fat dairy, the sources of protein and calcium. So those foods that we miss in the morning, we don't tend to make up later. And for those that skip meals, they have a tendency to rely more on snacks throughout the day instead of an actual meal itself. So focusing on meals and meal patterns really helps kind of focus people back to a consistent eating pattern that you can spread throughout the day, and then have an ability to structure that meal pattern in what they're consuming to help address those broader issues. Another area where people commonly overlook and overconsume is the role of foods and beverages. As we have sources of carbohydrates and energy and added sugars that are often masked in our drinks. The common assumption that fruit punch is fruit juice, because it says it contains 10% fruit juice. But the ability that the beverages have to contribute to both our energy for weight management, but also the carbohydrate and the added sugars that can have a significant impact on blood glucose, is one of those areas that is underappreciated, especially in individuals that may drink a large quantity of sugar sweetened beverages, of how much influence they have on blood glucose outcomes, but also how much control they have of improving blood glucose outcomes by managing those types of behaviors. We have some individuals that have very large quantities of sugar sweetened beverage consumption, and they are opposed to the non-caloric options, the diet beverages, that sort of thing. But we've talked in other sessions before about the ability to even dilute down half of it as a regular soda and half of it as diet, or 3/4 regular and 1/4 diet, to be able to start shifting that taste perception, that if they're going to not give up the soda, but being able to bring down the carbohydrate composition. And the same thing with coffees and our other various assorted coffee beverages that are now becoming more and more hip, the amount of fat and the amount of sugar that those provide. So thinking about them not only as the foods that they consume, but also the beverages. And finally, one other big strategy, as I kind of mentioned before, when we skip meals, we have a tendency to consume those more as snacks throughout the rest of the day, those kind of missing intakes. And what ultimately we're seeing is snacks contribute about 20 to 25% of the day's intake, which is essentially a 4th meal of the day. And snacks also contribute about 40% of the day's added sugars. So it's taking the lion's share of what we eat a little bit eat and drink throughout the day, not as part of a meal. And I always said, if we created a restaurant and we presented someone with a dinner only of the things that they eat as snacks, would they be appalled? Because we don't eat our snacks as meals. We eat our snacks as a little bit of something here, a little bit of something there, and when you add them together to be a meal's worth of intakes for the day, they're relatively low in protein, relatively high in sugar, relatively high in refined carbohydrate, and have a relatively poor diet quality. So what I show here is that the snacks and sweets and non-alcoholic beverages are making up about 55 to 60% of the calories that we get during snacking occasions. So these are going to have a considerable impact on blood glucose levels, but if it's also 1/4 of the day's intakes, these now have a considerable target for dietary behavior change to be able to help them with their food choices. So when we need to translate these guidelines of improving carbohydrate intake and understanding sources of carbohydrate and understanding sources of nutrients in meals and carbohydrates in meals, the U.S. Preventive Services Task Force recommends that you need moderate to high intensity lifestyle behavior change, which is 30 to 60 minutes for medium intensity and over 360 minutes of high intensity for lifestyle interventions to really facilitate changes within an individual. So reinforcement strategies will be helpful to be able to kind of start to move the needle. But for individuals who are going to need greater amounts of change, especially with individuals with higher hemoglobin A1Cs that we're trying to bring down, simple strategies will help get them started, but they're going to need more actionable strategies to really put this to their own limitations, to their own circumstance and situation, and help them apply these concepts that they can really make broader strides in being able to improve their lifestyle behaviors. So if reinforcement and this background is not one of your strengths, or you don't have enough time to be able to do that, consider scope of practice and licensure to refer to a dietitian, refer to a certified diabetes educator. Get these people to the ones who have more time to be able to spend on the particular details, and then the primary care provider can serve more of a role to help facilitate and reinforce those strategies. I know we're going to be talking a little bit later in the series about how we address an individual's lifestyle behavior. How we address lifestyle behaviors within a person's context and their social situation. There are lots of factors that are going to play in terms of food accessibility, food security, food availability, cooking skills, their resources, their time. There are other factors. So it becomes important to establish how we can incorporate these lifestyle behavior modifications within a person's life itself. Because one of the things that we continue to hear across the various ECHO sessions is that managing chronic conditions can be an intensive and personal situation, but it can also be exhausting for an individual who has to deal with lots of factors at play. So finding ways that we can make these more natural habits instead of a chore for change. And oftentimes those become more challenging for an individual compared to their other factors, or become less of a priority. But the ability to utilize the family structure or the social structure to provide an outlet for physical activity, for the benefits that will come from teaching children about their better lifestyle behaviors and the impacts that will have on their children and their children's health, to help provide other aspects that will motivate that change. And a lot of the recommendations that we have, and as I look at the various diabetes guidelines, they have a tendency to kind of focus on a lot of individual nutrients, where we really need to put this context around the foods that people consume and help them make those kinds of connections. So if we're looking at diabetes, foods that are really contributing carbohydrate to the diet, and to be able to kind of check off those foods that you're consuming during the day that are contributing to carbohydrate intake, gives them a much more concrete way of establishing how much am I consuming and how am I moving towards a healthier pattern, rather than I need to be decreasing my added sugars and I need to increase my fiber and I also need folate and magnesium. People eat foods instead of nutrients. So creating structures for them around kind of food and meal patterns that will help them better take those concepts around portion size and around the foods that contain carbohydrate and help them go from the concept to the fork. So from that, I will stop and be able to take questions, save some time for questions.
Hi, Chris. This is Austin Fredrickson. I'm out in Salem, Ohio. I'm a PCP there, and we're in the middle of cornfields. We've got one local hospital, so we have very few resources with dietitians. And then even we have the same issues of everyone who has more dietitians, time, cost. So if I have patients in my office, do you have a resource, or does anyone in this community have good YouTube resources or some other sort of resource that I could make my patients watch in there, so I'm not just repeating all the information, since it's pretty much just me and my MAs here, or something I can use to guide them for free while they're in my office, or direct them to do at home?
I can address
Anyone
that.
else?
Yeah, so thank you, Austin. There's a lot of resources available. I do a lot of work with the American Heart Association, which has Healthy Cooking for Heart. all of these things are available free to the general public as well. And I think even Jim and I, through our Fit or Me program, would be able to share some resources. But you touch upon an important point, and Chris pointed out the success of the diabetes prevention program. And so for my patient, the small number of my patients who are able to call the YMCA, which administers the program in many communities, show up every week, do exactly what they're supposed to do, they will achieve a much, not just prevention of diabetes, but it can also achieve a healthier weight and better control as well. But I think just in terms of, we could have a little discussion about what concrete recommendations, Chris, would you incorporate into an office visit? So I've got to check their hemoglobin A1C, their urinalysis, refer them to ophthalmology. I might have to check their feet at least once a year or so. Make sure they get a fasting lipid profile. Am I missing anything, Kathleen? Get them on an SGLT2, perhaps tell them to quit smoking, do some self-monitoring of glucose, reorder their strips, reorder their medications, and I have 30 minutes. So I've got 2 minutes left. What's that?
And get their flu shots and all the other.
Get their flu shot. Give them a parking pass because they're getting really annoyed because this is taking so long. But let's say I've got 2 minutes left. What would you tell them?
Right. And to kind of cycle back on the Austin's question and kind of fold that in, is that one of the things that I took out is if you look at the dietary recommendations across hypertension for DASH, across diabetes recommendations, which is not like a American Diabetes Association diet per se, but you have DASH, you have the MyPlate, you have the Mediterranean, they all have the same focus: eat more fruits and vegetables, eat more whole grains, reduce sugar sweetened beverage. What I think might be the easiest way in terms of when you've got 2 minutes with the patient, ask them about what it is that they're doing with their behavior and what is the one thing they'd be willing to change. Because in 2 minutes, you don't have enough time to assess their entire diet. And one of the common questions I've gotten from physicians in the past, if I could take one lab to get nutritional status, what would that be? Well, every nutrient acts like a drug, and you can't measure them all. And where if you have this aspect and this opportunity, you can even start with things like these are the types of things that I'm concerned about of foods that could be contributing to your carbohydrate intake and your A1C. Are there any of these foods that you would be, are there any of these areas that you would be comfortable in starting to make some changes and talk about what those would be? And that opens the door to kind of connect with what they're doing to how it impacts their metabolic status. And from there, at least it becomes a way to start the conversation. And I know Jim will be talking later on about motivational interviewing and kind of opening the door. So there you are, Jim, give you a little intro. So a way that we can then start that conversation and put it within a place where they feel like they can make changes. Because you're never going to change their favorite food, but if you can change their third favorite food or their fifth favorite food or the thing they eat somewhat regularly and make a little bit of change to that and see progress, then you can start to have impacts towards those higher level things that contribute. And Dr. Rao, I'm sorry, you also forgot to screen for mental health and for balance and
Medication compliance, adherence, cultural issues, socioeconomic status. Yeah, lots of things.
Yes.
Thank you, guys. That's really helpful advice. And then if you have any resources to either share after the session or in the comments, I'd love to see those. That would be really great.
So there are a couple of questions in the chat. I'll read this one. There's already a response, but maybe we can get your take on this, Dr. Taylor. From Christine Odia, I'm sorry if I say that wrong. I have a question about intermittent fasting. Is there anyone here who can recommend this? You know, I know I get a lot of questions about that as well. There's a response already from Matthew Black that is not recommended and provided a reference thus far. What's your take on that?
So first, the evidence around intermittent fasting is not robust in terms of making broad clinical recommendations around its impact. A lot of the elements that happen within fad diets are focused on very singular elements, whether it be weight loss. We were just having this discussion the other day about weight loss has a tendency to be the focus of a lot of where these dietary elements are concerned. When gluten-free came in and was cycling, everyone said, but I'm doing gluten-free and I feel so much better. And so you're eating less refined grain, you're eating more fruits and vegetables, you're eating more whole grains, you're drinking less sugar-sweetened beverages. It's not a surprise you're feeling better because you're eating better. It wasn't the gluten, it was the dietary behavior change. With intermittent fasting and some of these very low carbohydrate diets, et cetera, the focus is on the energy deficit to promote weight loss. But at the same time, reducing energy and losing weight doesn't automatically equate to nutritional adequacy. And you can't establish an entire quality of diet and healthfulness of a diet around just the amount of energy that someone consumes. So intermittent fasting is one of those that's a way to kind of bring down caloric intake. Basically, there was a comic that circulated around physicians talking to his patient. What I want you to do is try fasting between meals. Let's try and eat and then stop eating for a while, and then eat and then stop eating for a while. So there's not a lot of evidence around intermittent fasting on those impacts. We also had to consider what happens when somebody has that prolonged level of poor intake, and especially how does that then interact with their medications. So you have to then also consider if they're taking an insulin and they're taking insulin while they're not eating, what are those potential ramifications? So there's a lot more complicated things happening than I just need to get my energy intake down from intermittent fasting or from whatever those patterns might be.
And from my understanding, the intermittent fasting diet is not really intermittent. It's mostly fasting, right? I mean, a lot of these recommend, fasting for upwards, more than 12 hours for sure, but
right.
The vast majority of the day. And so you're only eating maybe 6, at most 8 hours a day, right? There was another question. Dietitians often limited in the number of visits that can that be extended for each patient?
Okay. This is actually something that, and I was like, oh, we're just a couple weeks too early we're about a session too early for this. I've got a student working on dietitian reimbursement within primary care. The comment that I'll make more broadly is a couple of years ago, we did a QI study with the dietitians. We had 2 dietitians that were full-time in family medicine. And they said, I could never come up with a research question. I wouldn't know what to do. But what I really want to know about my practice is, I know I bring in money, but I don't know how much. So we did the chart pool data to identify how many patients did they have referrals, how many showed, what were those referrals for, who was the insurance provider, and how much did they get reimbursed. And about 34%, 36% of the reimbursement that was received from both public and private payers was for glycemic control. What we ultimately determined was they were bringing in about twice their salary in reimbursement without a strategy to identify who is covering what. So they took it to the policy finance people, and they were able to get a 3rd dietitian because they could ultimately determine they could fund themselves. So it's identifying, and it always changes, and it depends on the plan, who are the providers that are covering what types of services, and considering which ones can you bill for. If you have dietitians, go back through and evaluate what it is that you've actually been billing for and been getting paid. It's kind of like the free school lunch and reduced price. A lot of times you can cover enough of everybody through one part to be able to provide services for the other. that if you're able to generate enough services from diabetes or from weight management, it may help you then have the access, as Austin was saying, if you have another patient that needs something that might not be reimbursable, but now you kind of have that service available because you've been able to build that infrastructure from the reimbursement you've been able to capture. So some of these patients will come in and get a referral for diabetes, and then later on they'll have another set of visits for referral for hypertension because they're related, and now it becomes a different process, which may be one of those aspects of addressing the number of visits, but that really just kind of becomes based on the coverage that they have.
Great. Well, I think we need to move on to our case. Thank you so much, Dr. Taylor. Could we actually have a little something new for you all to try to get a little bit of extra cooperation. Could we put up the slides? We have a couple of polling questions. And maybe we can talk about this some more after our case. So go ahead and submit your responses. What is your approach for implementing lifestyle changes in a person with diabetes? It's multiple choice. On this one, I believe you can choose more than one. Provide education in the office, refer to a dietitian, refer to a diabetes care and education specialist. Actually, it's supposed to be specialist. Sorry about that to all the CDCESs out there. And the last one is refer to diabetes self-management and education support program. So do we have, could we get the responses?
About 60% of you have voted. We'll give it about 20 more seconds, then we can share the results.
Thank you.
Okay, so if you haven't voted, get your votes in now. I'm going to share the results.
All right, so a lot of different methods and means. A lot of you do provide that education right in the office. I think that was one of the issues raised earlier is, you know, how do you get patients to come back? Great. Okay, we have one more polling question. Can we put that one up? All right, so this one's single choice. How does your clinic or institution handle education billing for Medicaid patients? So you incorporate it into your comprehensive care model. You refer to local free programs, collect a facility fee, or something else, or maybe you don't know. Go ahead and submit your responses.
Do you mean diabetes self-management education? Because the MNT is covered, you know, medical nutrition therapy is covered.
Yeah, diabetes self-management, yep. Okay, yeah, very interesting. More than half of you don't know how that is handled. So yeah, so it is interesting. It is probably handled somehow on the back end, would be my guess. But very interesting. Thank you for all for your responses. We're going to move on now to our case study.
I don't know how familiar everyone who's on this call is with the region. Southeastern Ohio, Athens is a little bubble, but as soon as you go outside the university bubble and all you have to do is travel, you know, 2 miles, you can see the extreme poverty. You know, Athens is the poorest county in the state. It has the highest food insecurity rate. So when he's talking about the social determinants of health, I mean, Southeastern Ohio has extreme issues. So talking about this individual, my first thought is I'm going to put, Dr. Prasudi, I'm going to give you the number to contact the community health worker who specializes in diabetes at our health department. She might be able to help. And the other thing is, and Dr. Prasudi, you know Sarah Adkins, right?
Yes.
So Sarah and I are opening a free pharmacy, and we're hoping to open it this month. And so I don't know if prescription drugs are an issue, but we're going to specialize in providing diabetes ones. But if she's not interested in insulin, that's a different issue, but we'll be providing diabetes medication. So if that's an issue as well, we'll be able to help with medications, but also if her children have medications too. And then we're hopefully going to be providing some of those with, delivery, so that transportation won't be as big of an issue. But I think the community health worker would be a very big help, because the community health worker provides a lot of support, and a lot of times it's support. And I've seen a couple of messages in the chat about, does she have depression, or is she experiencing some distress? And that's one of the things that the community health workers or any navigators provide. And she might not even be aware that she's experiencing that, but one of the biggest social determinants of health is a lack of support, and she might have a lack of support.
Well, I suspect that she does. She also does, actually, she doesn't live in Athens County, which makes it even more complicated. I think she lives in Morgan County, which is just north of Athens, because she lives in New Straitsville. So, I don't think, the other issue with her is that I think she's mildly intellectually disabled. She's kind of like borderline. So I think it makes it even more complicated with trying to explain things to her. So it's pretty challenging. She's been a very challenging patient to me over the years. So.
Yeah, a couple of the other comments in the chat, these are great. Does she have trouble with access to healthier foods? She's in a rural setting. She may have issues with transportation. Depression was another thought. Are there family members perhaps who can help manage? There's a couple of other comments on therapies. One suggestion was a GLP-1 that you can do once a week, and generally.
I did discuss that with her also, and she declined that also.
Mm-hmm. Yeah, and then another thought that at this A1C, insulin would still be the best option. Adam, are you back online? Okay, he tried to switch to headphones. Sharon thought she could share tips on how to get people to start insulin. I know that you had some nice tips that you shared on the quality improvement project last month.
Yeah, this is Sharon. I usually, for the really reticent patients, give them an injection of normal saline using an insulin syringe, and or try to get them an insulin pen if possible. And usually I explain to them that they have less nerve endings in their belly. They think it's going to hurt more to give an injection because they equate it to how it feels to check their blood glucose at their fingertips. And they're surprised to find out that they have less nerve endings in their belly and that it should hurt less. So yeah, go ahead.
I just wanted to add something that in Southeastern Ohio, there's in general across the US, there's stigma with type 2 diabetes, and there's people are reticent to start insulin. I've noticed being here the past 7 years, there's a different layer of stigma with type 2 diabetes. And it's a generational, that's passed down because we have such high rates of type 2. And I think it's added in with Appalachian culture. There is a diabetes fatalism that's going on. And so there's that, it's a different type of stigma and stereotyping that's happening. And it's different than what I've observed in other places that I've worked at, even with, insulin. So people hide their diabetes from each other, even within their family. And you do see this in other places, but it's different. So even people are very much against taking insulin, and because to them it means something very different. Because you see the amputations here, which you don't see in other places throughout the country anymore, because we made so many strides in medicine. So it's it's different down in Southeastern Ohio. You'd have to be here to experience and see it. And I'm sure Dr. Prasuti could talk about it.
There's a lot of really great conversations going on in the chat box. So make sure that if you don't have it open already, that you take a look at some of these. What about Dr. Werner? Did you want to chime in here, maybe on this idea of fatalism and you know, how the social determinants of health might play a role?
Sure. Yeah. You know, I would use a motivational interviewing approach to helping this patient change health behavior, just as an overall framework. And it has been shown to actually save time on the part of the clinician, although it may seem on the surface that these are extra steps. And in the long run, it saves a lot of time in counseling patients around health behavior. So really, you know, Dr. Prasuti already has a longstanding relationship with this patient, which is great. So the basis for any kind of health behavior change is that relationship. And really knowing what matters to that patient, what's most important, what do they really value. And I think another step would be to use the elicit, provide, elicit approach, which is simply to elicit from the patient, what do you already know about how blood sugar affects a person's health? And then once you know that, you can then, the door is open for you to provide more information to the patient about this. And then the second half of that elicit, provide, elicit is, or the third part, is just asking, so what does that mean for you in the context of your life? So then what, you know, because you already know what the patient values, what really the kind of the approach would be is to develop discrepancy between what they value and where they're headed with their health, and allow the patient to look at those two things at the same time in a safe place with you, because they may have kind of walled that off. So, you know, a question would be, you know, how does monitoring your blood glucose fit in with the things that matter most to you in your life? And so then you're finding out from the patient how they weigh these things out in their mind and how these values and goals fit with their current health behavior. And this can lead the way then to, you know, I liked Chris's question too, you know, at the end of a visit, simply saying, you know, we discussed this and this and this today about coming from the elicit, provide, elicit, the information you provided. We also talked about the fact that your family is so important to you, but diabetes threatens that a little bit. What would be one thing that you'd be willing to focus on today? So that would be my approach. I'll stop there.
Great. And does anyone have thoughts about, you know, are there other, so, you know, family history of diabetes is really common in many different populations. And so this whole idea of how that plays into how you view diabetes and you know, whether it's an inevitability and if there's something that you can do to prevent or at least really effectively manage that. Are there other populations that we should be thinking about? You know, for example, African-American populations, you know, there are many other populations where diabetes is really strongly inherited. Adam's
Kathleen,
back.
this is Adam. Sorry about
Hi.
that. Are you guys able to hear me okay?
Yep.
Good. So I guess one of the things I was thinking was that the case presentation started off with a statement that it's been challenging to keep this patient in regular care. And so one of the frameworks for thinking about social needs and social determinants of health is really a form of root cause analysis. And so thinking about, you know, asking, and there are a few approaches to this. One that we're highlighting in some upcoming presentations is the 5 whys approach, but really sort of just walking through and asking, okay, well, this patient says that they're unable to get to the appointment today, or that they missed their last 3 appointments. Well, why was that? Well, they didn't have transportation. Well, why was that? Well, their car was broken. Well, why was that? Because they ran out of money for something and they've not been able to pay for the car for several months. Right? Well, why was that? Well, because they lost their job due to the COVID-19 pandemic, right? So really working through with the person, and that because sometimes the social need that somebody presents with is not necessarily the one that is the root cause of the challenges that they're facing. And so really, this is a hard thing to do clinically, but it's also the kind of thing that can be helpful in bridging some trust and understanding with patients about how what is the basis for the challenge that they're having with getting to an appointment or picking up a medicine or staying in regular care.
Well, I think that's all the time we have available today. We do, as I said, we do have that post test survey. Shannon?
Yep, you should have received it in your inbox at 8:45 this morning, and thank you for completing that by tomorrow at 5 o'clock. And also, if you ever miss an echo clinic, you can view it on our website if you register. Next week, we have Dr. Dungan with new and emerging therapies for type 2 diabetes. Thanks for joining us today, everyone. Have a great week.
Thanks, everyone.
Bye.
Bye.